Hello, good evening, everybody. You're welcome once again to today's edition, which is the third part of the lectures on the shoulder at the NOA Zoom learning session. We have with us again, hopefully not for the last time, Dr. Mark Lutonia, who is an orthopedic surgeon and a senior lecturer at Egerton University Medical School, which is in Nakuru in Kenya. And he has been board certified since 2009, had his undergraduates in the University of Nairobi and postgraduates at the Moi and Pretoria universities respectively. He's had post-qualification training in arthroplasty, in arthroscopy and spine at their suit, and later revision arthroplasty and shoulder replacement in Zurich. His interests are in shoulder surgery, in scopes and spine, and he's been doing reverse total shoulder arthroplasty since 2017. He teaches and works for the Association for the Study of Internal Fixation, or the AO. I won't bore you with the long German name. And he's vice president of the East African Arthroscopy Association as well. We've had 3 lectures all back to back in the last, say, 10 days, thereabouts. And we started off with biomechanics of the shoulder joints, moved on to biomechanics of the shoulder replacement, the procedure, the different processes, the design. Was a beautiful lecture. And today we're concluding with a lecture which is very dear to my heart, because here in Africa, we have patients who we probably may never be able to replace for all sorts of reasons. And for these, we need to talk about alternatives to arthroplasty. So I'm very, very pleased to welcome Mark once again. We've had a couple of issues with people being unmuted. So what I'm going to do now is just make it easy for all of us. I'll mute everybody, and then Mark, please kindly unmute yourself, because that does make it, a bit tidier.
Can you hear me?
No, you need to unmute yourself, I think. So I have asked you to unmute. Are you able to?
Can you hear me now?
We can hear you now. So I think this solves the problems we had in the last 2 sessions. Question and answer period, comments and all of that, please type them into the chat box. Once the lecture is done and Mark is ready to take questions and comments, we'll unmute everybody and we can just have a really nice discussion. If you have cases that you'd like to share with us as well, anything interesting, you're welcome. The other thing to state is that we're open for people who want to take topics to teach on this platform. And the curriculum is on Telegram. The people who have signed up properly will have access to that. If you don't have access to the Telegram group, I'm happy to put the link up later, so please ask for it. And you can look through the curriculum and feel free to say what you think we should be adding or subtracting and how you can help, including administrative work as well. We're not just non-profit, we're completely unpaid. So you're very welcome to join in the fun as well. All right, Mark, you're welcome, and please go ahead.
Thank you very much, Dr. Olukemi. Welcome to the third part of this series of lectures. And I know that for this season, it is the last, although Dr. Olukemi says hopefully not the last. Today we are looking at the other things somebody can do when arthroplasty is not an option that is on the table, or before arthroplasty becomes an option. So I will introduce the topic, outline the scope and discuss, and then conclude. Shoulder surgery is fast evolving, and there are a lot of innovations happening, especially in the replacement. And the outcomes, as we study the outcomes are improving. A lot of new science is emerging. And so when things come on board, they tend to be like in vogue. But it is known to the people who do arthroplasty that it has, or apart from having predictable or fairly predictable and good results, there is a fair share of complications that comes with arthroplasty. And the problem with arthroplasty is once you take the path to replace, you can't come back. You see, you excise parts of the bones, and so you render the joint inadequate for some of this salvage or some of these alternative procedures that I'll be talking about. And so it's a path of no return. So for this reason, one would like to see if there is in his or her armamentarium other options that can be useful before arthroplasty becomes the only option. The only way to avoid, of course, a surgical complication is to avoid the surgery, to quote some of our senior teachers. But you will see that some of these alternative procedures that are available are really surgical options. Just that there might be situations when shoulder replacement in terms of arthroplasty is undesirable or is unavailable or is unwarranted. So for example, in young children, and we look at some of these situations, we'll sample the situations that make shoulder replacement unavailable or unwarranted. For example, generally, we say that patients who are younger than 50 should not receive shoulder arthroplasty. As I've always said, it is my opinion that this situation has variations, because in some cases, there is absolutely nothing that you can offer the patient to give good function. And some of these rules were really set before we realized the outcomes of some of the replacement options and the implant improvements that we now have. But generally, one would frown at situations where you need to do a total shoulder replacement in a patient who is younger than, say, 40, 50 years old. So it is important to consider all the other options that may be available for that patient if that is the age you're dealing with. The patient could decline and render him or herself available to other options other than replacements due to their own guidance or information. The patients who have near normal function, like even if they have pain, they only have pain, but they have near normal function, one must be aware that attempting to replace them might not give them similar function like they had prior to that. And so in those patients, other mechanisms might be put in place to manage pain. Failed arthroplasties, in that case, then you need some of the procedures that we'll talk about that are alternatives. If the patient has neuromuscular disease like brachial plexus injury that you are unable to remedy by muscle transfers or by nerve repairs, you have deltoid denervation, or you have severe, say, scapulothoracic movement problems, and then some of these replacements might not work. If there is an ongoing infection, and if there is one-sided focal degeneration, say the humerus is good, the glenoid is bad, or the glenoid is good and the humerus is bad, in such situations, one might need other procedures that do not necessarily involve total shoulder joint replacement. In patients who have high demands, they are going to input a lot of needs on those joints. And so you might want to avoid those joints until the time when the patient is willing to modify their lifestyle. And of course, as I mentioned, in children, arthroplasty is out of our reach. So in this discussion, we shall briefly mention the non-operative interventions that are available to you. I know you know most of these things, and some of them are easy to just brush through. I'll just mention a few things that one may want to remember and quickly go to the operative interventions that are basically either open procedures or arthroscopic assisted procedures. So as we will sift through them and see what we can get. So some of the operative interventions we look at are cord decompression, osteotomies around the glenoid, osteotomies around the humerus, resurfacing of the head, either partial or complete resurfacing of the head of humerus, glenoid resurfacing or interposition of grafts, microfractures, which are basically arthroscopic or open, arthroscopic debridement and its role, resection, arthroplasty, and arthrodesis. So we'll start with the injections. Basically, when the shoulder has pain, it is very important to evaluate the patient to determine if the disease is involving structures surrounding the shoulder or the shoulder joint, the glenohumeral joint itself. Because painful acromioclavicular disease, painful sternoclavicular disease, painful muscle tears, impingement around the acromion, tears of the labrum may not necessarily be arthritic and they may not necessarily require joint replacements. It is when you have severe damage of the cartilage lining of both bones that we usually should think about replacement. So there is so much pathology around the shoulder that can be remedied by some of these injections. Now, when tissue is torn, sometimes it goes into this chronic phase where it is unable to resolve, that it's unable to heal. That now informs this science behind this proliferative injection therapy, which is basically abbreviated as prolotherapy, which now is almost becoming a branch of joint saving surgery in many of these arthroscopy and sports medicine fields, that some people will graduate and actually go into this. Now, it is bigger than just the shoulder. We have areas, things like, muscle myofascial pains, things like trigger points, things like plantar fasciitis, things like elbow epicondylitis, things, and of course within the shoulder we are looking at tenosynovitis of the rotator cuff or subacromial impingement. So the thinking is that this tissue may be torn or inflamed. And when it is torn, especially, particularly, let's say a tendon is torn and is partial, it's not complete, one of the options you can offer the patient is injection of proliferative causing agents. And some of these agents we know, most of us just practice injection of corticosteroids in the joints, but there are other, proliferative agents that you can inject in the joint, starting simply with dextrose. Now, so the intracellular content of dextrose is about 0.1. But once cells are exposed to dextrose concentration above 0.5, they start to proliferate, cells start to proliferate. So what has been shown that if you inject injured cells with concentration of dextrose below 10%, you excite cellular division and so proliferation. If, however, you inject with concentrations above 10, then on top of that proliferation, you also excite formation of inflammation. And this inflammation causes new tissue together with the influx of chemicals that cause growth, like growth factors. And so this can actually encourage tissue to heal. Even collagen forms, new cells, and fibrous tissue. And what has been shown is that if you inject areas that are torn, like for example, epicondylitis, when you tear the ERCB and we inject there, then the proliferation of this new tissue will link the tendon to its torn bed and be able to generate tissue that can help the tendon to contract without pain. So dextrose is one of the things you can inject in these painful shoulders. PG2 is actually a combination of dextrose, glycerin, and phenol. Pume is sodium morphate. We use sodium morphate a lot when we want to proliferate tissue inside vessels so that we can block vessels that have these varicose veins. We can also use sodium morphate to inject epicondylitis and areas where we want inflammation to cause tissue healing. Lipoaspirate used to be sold as Sinasol, a fatty acid derivative. Now, these days, I don't know whether it is available. In Kenya, we have to look for it, I'm not sure. But Sinasol used to be available as a fatty acid derivative that you can inject, which is also a prolotherapy. And then other forms of prolotherapy include PRP. PRP basically is platelet-rich plasma. You take blood from the same patient, centrifuge it, and take the layer that has platelets with the plasma. Now, these platelets come with platelet-derived growth factors that are able to cause tissue regeneration. So these are things, and then the last aspect of prolotherapy involves stem cells, where stem cells are centrifuged and a certain layer that has, you actually get bone marrow from the iliac crest. You can aspirate, or from the sternum, you aspirate bone marrow, centrifuge it, and take the layer that has stem cells and inject in that area. I think all these are proliferative therapy injections. You're injecting proliferants, and these will be applicable when we have things like supraspinatus partial tendon tear, subscapular, those kind of tendon tears, and the patient is not yet ready for arthroplasty. Of course, in those situations, you really don't need arthroplasty. The interesting thing here is that if you have cartilage damage, for example, if you have cartilage damage, you can also inject these things. And that informs why we do microfracture. Actually, when we microfracture after cleaning, is you create a fresh bed, you drill, and then bone marrow comes out, and this gives sort of stem cells there that cause proliferation of fibroblasts, and these fibroblasts make fibrofatty tissue that is able to act almost like cartilage. So this prolotherapy is aimed at regenerating these tissues, including torn tendons and cartilage that may be damaged if it is not so much. I think the most important thing about a successful prolotherapy is to evaluate your patient to see that the patient indeed does not have this other severe osteoarthritic damage. The patient has maybe partial tears of tendons and has pain arising from that. And then you inject using ultrasound. Ultrasound will improve your outcome because you'll target the lesion. Then it is said you should immobilize it for some time to allow it to work. And then you can start graduated activity. The outcomes of this seem to be not so bad, with the pain relief going up to upwards of 80–85%, in some studies 90%. But I think those articles that will usually give you those very high percentages of pain resolution might be that there is some influence from the company that is manufacturing some of these machines that you use to do this work. So although many practicing orthopedic surgeons still frown at these prolotherapy options, it is good to have a look at them. And some of these companies provide these machines for free. And if you can be able to offer them, especially for the patient who is not yet ripe for arthroplasty, then it is not such a bad idea. The ideal patient, as I've said, will be early cartilage lesions or patients undergoing salvage procedures after arthroscopy. Maybe you've repaired your tendon and you want to enhance its healing, or sprains and soft tissue induced tears. The outcomes are good. Expect some soreness if you inject. For example, sodium morphate is a very abrasive chemical. Whenever we use it, if it leaks outside the skin, it is likely to cause burns, and it can cause chronic ulcers that don't heal, so they need to be injected quite deep. The safest of them is dextrose. Dextrose is unlikely to give you this kind of burns. Expect mild to modest improvements in range of motion, and usually you expect pain relief is in more than half of your clients. I don't think there is much to mention about NSAIDs, physiotherapy, and cortisone. And viscose supplementation is something that is still being discussed. I don't use viscose supplementation, but because it is one of the things in the literature, I'll probably just mention it. NSAIDs and cortisone make the mainstay of people, practice, who want anybody who has little whatever about the shoulder, usually wants to, oh, you have pain under the shoulder, okay, come here, we put an injection and that kind of thing. We need to start understanding what you're doing. NSAIDs, of course, there's no problem, you're relieving pain. In situations that have mild to moderate pain from tendinitis or bursitis and impingement, it is possible to relieve this by physio and NSAIDs for a course for a week or two. And what we know is that when you have tissue injury, you cause inflammation. Let's say, so the inflammation you bring in cells, the PMNs, macrophages, they come in to maybe engulf and eat away the debris, the dead tissue. And with influx of these cells, they release more chemicals. These chemicals cause greater inflammation, vessels opening up and more tissue edema. It is this tissue edema that is said to cause stasis. And the stasis stops the tissue now because retards circulation. When you have retarded circulation, you get some kind of ischemia, almost like the way like when you get a tourniquet, and so you get pain. And that is how this inflammation causes pain. So cortisone comes in by trying to prevent ingress or entry of macrophages and polymorphonuclear leukocytes into a tissue that is getting injured or inflamed. So in the early phase, it will prevent mobilization of PMNs. It also inhibits capillary vasodilation that would have been caused by those chemicals from inflammation, and then prevents formation of vasoactive bradykinins or these kinins. And also lately, we think that it also prevents release of arachidonic acid from the phospholipids. Now, so by this way, steroids actually are very effective anti-inflammatory medication. One must know that a steroid alone will take some time because you know the mechanism of action of steroids, it has to go to the cell, to the nucleus and stuff like that, protein. And so it takes a few days for the steroids to be effective. So most of the time when you inject these steroids, you need to either add lidocaine for you to be sure that you have injected it at the right place, or to tell the patient that the first few days might be painful, and so add some NSAIDs so that by the time the steroid is picking up, it has taken some time the NSAIDs have helped the patient not to be in a lot of pain. But you need to know that a careless use of steroids can cause complete tear of the tendons, because in the first few days, say up to 2 weeks after injection of steroids, they tend to weaken the tendons, sort of to make them a bit easier to rupture. So if this patient is a weightlifter or is a heavy sports person, maybe it's wiser to limit them from doing sports in the first 2 weeks or so. Steroids also have this problem of increasing sugar. They might, in the first 7 days, most of the studies have shown that up to 10 days, you need to follow up patients, especially those who are diabetic. Maybe those who are not diabetic, it might not be a big problem, but those who are borderline or well controlled and now you inject them steroids, it is good to know that the first 10 days you might need to follow them up because of hyperglycemia and react appropriately. They might also worsen AVN. If there is an AVN ongoing, then steroids might not be good. So patients who are at risk already of AVN, patients who, for example, are alcoholic, patients who have already any evidence of maybe cruise stage 1 or 2 AVN, you don't want to send them to give them steroids, which means that you should have evaluated your patient well, either by clinical examination and MRI evaluation to make sure that you're not giving steroids to the wrong patients. Steroids can also be injected inside the joint to reduce pain. And I tend to use pain for those patients who are, because steroid is anti-inflammatory. The sign of inflammation that we usually know is effusion. So I'll usually give a steroid in a patient who has an effusive joint disease, joint arthritis. So a dry joint is unlikely to give you good results when you give steroids, but a wet joint that is effusive is more likely to react to your steroid injection better. So in those kind of situations, then one might inject steroids directly into the joint. The ones that I was talking about were steroids above the joint in the subacromial region. Physiotherapy, on the other hand, improves scapulothoracic rhythm. I think if you remember when we talked about the biomechanics class, we talked about this imbalance in the scapulothoracic posture that causes the scapula to look above and thereby face the acromion and then maybe impinge or constrict the space under the acromion. And when you trained, and I told the attendees that maybe sometimes I send patients to do press-ups to build up their scapulothoracic muscles. And so that kind of training rhythm, improving the scapulothoracic rhythm and posture and balance of the position of the scapula can improve pain. In some cases, actually vanquish that pain. It also improves strength. Proprioception improves the proprioception. And when the patient's proprioception is better, they are more likely to position the joint in a position that is not painful. Also improving circulation by reducing edema, because muscles are able to pump away the edema. As we said, edema that is associated with inflammation causes stasis, and the stasis causes like some kind of ischemia and pain as a result. So physiotherapy is your sort of friend in all painful shoulder conditions. Having exhausted or mentioned the few I think for viscosupplementation, the only thing I could say is that there is still a lot of question marks on this. And I personally don't use viscosupplementation, but there are some centers where viscosupplementation is used. And of course, the ones who use it would like to get good results. I don't know whether those results are superior to placebo. I think that is something that can depend on units. It's better to use, some kind of image assist so that if you are able to give those viscosupplements, then you are putting them in the right place. I don't think there is role for viscosupplementation for maybe tendon ruptures and stuff. Maybe that is just as a lubricant in the joint, but I don't use that. Now, as far as operative interventions are concerned, in patients who have AVN, there is an option like the patient on the left, where you can see refaction of the subchondral bone just below the articular surface of the humerus, and the glenoid looking nice. These are the type of patients who can benefit from operation by core decompression. So the whole point here is just to drill the subchondral region of the bone and maybe cause bleeding into this area, into this crescent collapse, and then maybe help regeneration of new subchondral bone. It has been said, and I've tried this not in the shoulder. I've done this a lot around the knee and femur, especially femur in some young boys, and found that it is remarkable in pain relief. And so I am not surprised that in the shoulder it also offers good pain relief. The only thing here is to try and either use, you can use arthroscopy assist, so that the arthroscope is able to help you to localize where the drill should come, and you use a CM, or you can use if you have localized with the arthroscope, you have seen where the defect is, you can put in an SEL guide. So you put in an SEL guide and you drill towards the tip. Actually, the use of the SEL guide is a new thing that is very helpful. So if I'm gonna do this, I'll just be using the SEL guide. So, and then you drill from the outside. Of course, you try to avoid things like the biceps tendon. You drill through the deltoid. This is for cruise stage 3 and below. Once you have above 4 and 5 cruise stage, it's unlikely that you will get good relief in pain, relief from patients with the AVN. It's better, this process, when it is combined, the outcomes become better when you combine it with other procedures like arthroscopic debridement. So this will be in a situation where you've done a scope, seen pathologies around the shoulder, sorted them, say labral debridements, you've done subacromial decompression, acromioclavicular joint, maybe excision of the clavicle or something like that. And then you come back to the joint and you find there is a lesion. You check and you see that, and you've done an MRI, of course. Then now you can combine it with core decompression. It should give you good results if you get multiple cores. Sometimes you have to drill several times before you get the target where you want. It is wise to try and really avoid over-penetration of that, because it can cause chondrolysis. So what some people will do is, if they notice that they are not able to target that place, is they run in a small wire, and once that wire is seen arthroscopically, then they can drill on that wire, but shy of the articular surface. Now, Benjamin, long time ago, realized that some of these patients who could not be replaced, and those times when there was not so much replacement happening, that he could just cause a fracture around the glenoid and a fracture around the humerus, and that sort of seemed to make, if I may call it, what do you call this joint that is, like now the glenohumeral joint is rendered, what do you call when you have a fracture up and down the joint? So like floating, yes, but although that's not the real definition of a floating shoulder, because for floating shoulder we usually talk of the clavicle. But in this case, if you could look at the glenohumeral joint floating, so you cause a fracture in the metaphyseal region of the humerus, just at the surgical neck, and you cause another fracture around the glenoid neck. Usually, this will be by a deltopectoral approach. You do an osteotomy shy of the glenoid surface, and you go up to the posterior, complete cut through. You leave the periosteum posteriorly only, and then also you cut on the humerus, and you just fracture them like that. You don't fix them. You don't fix them. You leave in a sling for some 4 to 6 weeks, and then you mobilize. Actually, if they usually will go ahead and unite, and that's what you want. In fact, non-union could result in some residual pain, but remarkable pain improvement in patients you may not be able to replace. So this could be of use, say, in patients who have declined surgery to replace, or patients who are salvaging and they are still in pain. You have removed the implants or something like that, or they have too many cysts, big cysts that you are unable to. Of course, most of these indications that were there for this kind of procedures, we have now been able to sort. But in the event that you do not have ability to sort, this is one of the options that you can give. They give good pain relief, and surprisingly, according to some textbooks, that they also increase the range of motion. I would expect more pain relief than range of motion improvement. I don't know the mechanism. It is thought, the last I checked about this, it is thought that the fracturing results in increased blood supply around the shoulder. And that increased blood supply seems to sort of relieve pain. But other people used to think it's denervation that causes the shoulder pain to resolve. Now, the kind of osteotomies that are more important to us currently are these ones that turn the shape of the glenoid. We all know the ABC classification of the glenoid bone loss. I will look at the glenoid first, and then we'll go at humerus derotating osteotomies. And the glenoids that have retroverted, because most of the time, most people in the past have done procedures that imbricate the capsule anteriorly, like putty-plat and procedures like that, because instabilities tend to happen anteriorly. So what that does is the capsule anteriorly and the structures anteriorly become tight. As the structures anteriorly become tight, there is a tendency for the head of the humerus to face posteriorly, and that put pressure on the posterior part of the glenoid. So it is not uncommon to find that the glenoid is deficient posteriorly in what we call a biconcave, like that B2 image, a biconcave glenoid. These are the ones that render themselves, if the cartilage on that glenoid part that is depressed is not so much damaged, these are the ones that render themselves to very good osteotomies of the glenoid from a posterior approach. You go through the interval between the infraspinators, you push away or you split the deltoid, and then along its fibers. Then you go between the infraspinators and teres minor, split it to the joint, and then you can lift off a little bit of the teres minor, reattach later, you'll be on the capsule. And then right there, you can use CM, or you can have measured by CT scan, and now you know what you want to do. Most of the time people want to make sure, so you release the capsule, you dissect off the capsule, and then you can be able to see the joint. So now once you see the joint, you can now target your osteotomy to exit. You don't want it to exit through the joint per se, but you want it to hinge on that crista line that is in the cartilage of the glenoid joint. Then you make an osteotomy, you lift it off until you have angulated it properly. Now it is ready to receive the head of the humerus without it subluxing posteriorly. Sometimes this procedure is combined with the anterior capsular release, which can be done arthroscopic, or it can be done open. You turn the patient and do an anterior capsular release so that you can be able to recenter the humerus so that it is not facing posteriorly. This has good outcome. You can get the bone grafts to put there, the wedge bone graft, you can get it from the spine. You can actually cut off a chip of bone from the spine and put there. If you're not happy with this, you can get the bone from the iliac crest. and put it there like it's shown in the diagram on the right. And your final effect should look a glenoid like the one, the X-ray on the far right, where the glenoid was retroverted completely with the posterior bone loss. And now after implantation and incorporation of the graft, the glenoid is properly receiving the humerus, and you can see the rotation of the humerus has been managed to receive the glenoid properly. So these kind of glenoid articular osteotomies or wedge osteotomies of the glenoid are very useful in cases of biconcave glenoid. Now, of course, combined with other things like, because this must have started with some pathology and maybe other surgeries have been done. Now, sometimes you find that the part of the glenoid that is depressed is also is denuded of cartilage. So in this case, another option that one has is to input the capsule that you have mobilized from the glenoid. You can, using suture anchors, you can go to that crista area, put in suture anchors, maybe 2 or 3, deep so that they are not on the glenoid surface. And once they are ready to receive a suture, then you can capture the capsule, which now will externally rotate the humerus as is shown in that E, so that now the capsule is not being reattached at the edge of the glenoid or on the labrum. Rather, the capsule is being reattached at the center of the joint on that crista. So in that case, you have actually combined an osteotomy with an interposition capsulorrhaphy. So the capsule here is acting as an interposition agent, or so the way we will use meniscus in forthcoming discussion. Now, the outcomes, by the way, of these osteotomies of the outcomes of the osteotomies of the glenoid is good, actually. And the good thing with this is that you don't want to use, by the way, metallic implants. Prefer bioabsorbable screws, because should we come in future to replace, we want to be able to replace. But the outcomes are good in terms of pain, stability, and range of motion. So this is a good option. And of course, you'll have worked up the patient with CT scan to know whether you should offer your patient this kind of surgery. Then there is humeral derotation osteotomies. Humeral derotation osteotomies are generally for young children. If the child has an articular defect on the humerus, you want to rotate such that the articular part is less damaged or something like that. Of course, if you're doing that for that reason, then it's likely you can cause instability. For example, if you retrovert the humerus even more, you can cause posterior instability. So you might want to combine it with a capsular imbrication and vice versa. But then you can also do it when there was already instability. Let's say, for example, there was instability posteriorly. So the humerus has the tendency to keep dislocating posteriorly. So what you do, you antevert this humerus, you make an osteotomy in the surgical neck area, antevert this humerus so that it doesn't have that chance so that to dislocate posteriorly, and vice versa. If there is instability anteriorly, you retrovert the humerus. And sometimes it is thought after you do a CT scan that some of these patients who require these surgeries have already congenital abnormalities of retroversion or excess anteversion of the humerus, and so you're attempting to correct. You can see that we usually use the biceps tendon as the measure for our rotation. You can put wires along that, a wire up on the biceps, up in the subscap tunnel, and a wire down. And then as you rotate, you can decide how much rotation by measuring how much parting you'll get from those wires in terms of degrees, and then you fix it with a plate. You, of course, can realize that you're going to change the biomechanics of the biceps tendon, and sometimes you might have to do a little bit of that tunnelplasty for the biceps to be able to work well. But this is an option that you can offer. Sometimes also, if there is a damage, so some people could even combine this as osteotomy with repair of the glenoid. So if you have done a posterior glenoid repair, then you combine it with an anteverting osteotomy so that you do not continue to have damage at that repaired site. Most of the time, though, people who do glenoid osteotomy will do that alone and maybe capsular release, not derotating osteotomy. Derotating osteotomies tend to be useful in the young children who still have growing bones. Of note is just to mention the humeral head resurfacing. I think one could look at this as a kind of arthroplasty. I don't know whether to look at this as an alternative to arthroplasty, but then there is this other option where, okay, so in the usual arthroplasty, we have a stem, and then we have this where you are putting just the head, the articular part, and then we even have what is called the extended articulating surface, or the AES, extended articulating surface cap. So in this case, we prepare, like you can see in the image below, we prepare the head of humerus. And the beauty here is that now there is no version anti-version issues, because you can see you're preparing the head because you can see it. And this will be very useful when you have things like AVN and there is a huge part of the head that you are unable to reconstruct. Then you can implant this kind of stuff. It's bone saving. You do not destroy a lot of bone by putting stems and inlay implants. You need to tension you tension your rotator cuff very well, because you know this is relying on an intact rotator cuff. So you need this head at the right place. So you need to understand the size of your head that you want to use to resurface. Make sure that you do not lateralize the humerus so much you may not be able to repair the rotator cuff. You must have an intact rotator cuff, of course, to do this kind of procedure. There is also innovative, I think they have, there are several companies that have these resurfacing implants. Aqualis, I think, Aqualis. They also have where the damage is not so much. You have a patch, say, let's say 3 by 2 centimeters damage, and you have chosen not to do microfracture. You can just prepare that place and put a partial resurfacing. So we have partial resurfacing that are shaped depending on the site where the damage is, just like we do in the femur, what is called partial or patellofemoral arthroplasty. Something like that, patellofemoral arthroplasty, but in this case, you're doing it in the humerus. Now, if we shift our focus to the glenoid, there is also options where you can put allografts like menisci, like in the right image where you drill holes in you prepare the meniscus by debriding it, you debride and release the capsule off, and then you drill holes all around the edge of the glenoid and pass sutures. And then you can do this open like is shown in the picture on the left, but you can also do this arthroscopic, where you can implant this arthroscopic where you pass those sutures and you label those sutures from outside. Then you pass them into your native meniscus. Of course, now this is more technical. You are watching how the meniscus will go in, then you pull on those sutures and they implant the meniscus. What I think is easier for people to do is to do the open one, and you implant. You can even use suture anchors. You can use biabsorbable suture anchors if you don't want, or you don't have a mechanism. But it is relatively easy to drill on the edge of the glenoid, because the glenoid is curved, rendering itself to a drill. But if in the event that you're not able to, you can use suture anchors. You might actually find use of suture anchors is harder to use than just drilling holes and capturing the way it has been shown here. Most of the time, resurfacing of the glenoid is done in conjunction with hemiarthroplasty. One must know that resurfacing does not prevent progressive medialization of the head. It doesn't. And actually, there are some people who think that resurfacing, they don't even do resurfacing of the glenoid because they think that it doesn't, apart from relieving pain, because it does relieve pain, it does not prevent progress of the arthritis, especially medialization. It doesn't save the glenoid from damage. So they would prefer other things that will save the glenoid from damage. The options you have other than the meniscus is you can get implants that you can get, fascia lata. You can get tendons like tendo Achilles. They can be allograft, or you can get them peroneal, as long as you can harvest from the patient and fashion them into meniscus like conduits, and then you can implant on the glenoid. So it is possible for you to do that to reduce pain. Glenoid resurfacing. Arthroscopic debridement. It's a powerful adjunct for people who do arthroscopy, who are able to do arthroscopy to be able to debride the shoulder. I think it has a very big role in patients who have rheumatoid arthritis, because they tend to have a lot of synovitis, and the synovitis can cause them pain. There are other situations where you have a lot of osteophytes, but the damage itself on the glenoid is not so much, but you have age osteophytes both on the glenoid and on the humerus. So you can do osteophytectomy. You can also, after reducing those osteophytes, removing them, you can be able to lift off the capsule and do a capsulorrhaphy or release that capsule, and or imbricate the capsule if you're unstable. While there, sometimes people will do a biceps tenodesis. You cut off the biceps from on top there and you capture it arthroscopically and implant it on the tissues around the pectoralis and subscapularis tunnel. This has been shown to reduce pain, although some people say that it will make the head to migrate upwards, but it is effective in reducing pain, and also you can retension the biceps and be able to help the patient to use the elbow more effectively. You can, while at it, at arthroscopy, do a chromioplasty and coracoidplasty if there are any impingements, and so be able to relieve pain. I think that before you go in for arthroscopic solution of shoulder pain, you need to have worked up the patient very well. And if you already know that the patient is arthritic, then you must have certain targets that you want, because we know that it is not advisable to do arthroscopy in arthritic joints in general. Like, for example, you have an arthritic knee, you're not going to do arthroscopy that you're going just to debride. But in the shoulder, for some reason, the thinking is a bit different. In the shoulder, you can still go in and debride that joint, decompress the subacromial region, remove impingement issues, remove the osteophytes, and if you have a chance, you can do microfracture for areas that are damaged, cartilage damaged. You can do capsular release, and you can do biceps tenodesis. You can even remove foreign bodies. There's a lot that you can do around the shoulder. And so for the shoulder, it is not entirely true to say arthroscopic debridement is not indicated. In the other knee joints like knee and hip, I think we usually say arthroscopic debridement is not okay, unless maybe you're just going to relieve locking issues and you are not yet ready to put a joint. So for the shoulder, the thinking is a little bit different, and arthroscopy has a role, and it has been shown to reduce pain if you combine all those many procedures in one. So like in this case, arthroscopy has been done, and you can see that there is a defect on the left, a cartilage defect with fraying. It has, we can classify this using outer bridge and see where it has reached. It has reached the subchondral bone. So we clean up this area to a fresh edge, like you can see on the right, and then we puncture 2 millimeter deep, 2 millimeter wide holes, like you can see on the right. You can do this using microfracture, whatever we have instruments for this, or either powered or manual on the glenoid and on the humerus. And what happens is bone marrow comes out, and then you get a fibrofatty layer there that is able to act just like cartilage. It is very effective. It is fairly effective in pain relief, this procedure, and it is worth trying for defects that are less than 2 centimeters squared. Finally, Tillman and Gariepi, they described resection arthroplasty. There is 2 types of resection arthroplasty. There is resection arthroplasty before arthroplasty. That is, you're doing resection arthroplasty, you have decided that you are not going to replace these patients, they have some pain, and you want to do resection arthroplasty, in which case you do a transdeltoid approach, part the deltoid, reach the joint, remove the usually, of course, there's some flimsy rotator cuff or something like that, detach it, reduce that head of the humerus, reduce it, sort of like chop it and remove all the osteophytes that you might want to remove, reduce that head, and then you can decide to, if you're using the method by Gariepi, to abrade the glenoid also, or if Tillman discouraged abrasion of the glenoid because he thinks that you need the glenoid bone stock. So if you're doing it as of Tillman, then you can use lyophilized dura or fascia lata and cover the head of the humerus after you have excised or reduced the size of that head. That is the old resection arthroplasty described by Tillman. this is also combined with synovectomy. You do the synovectomy in the areas that you can see, and this has been shown to improve pain scores and also increase the range of motion. Lyophilized dura is really just frozen dried dura. So they take dura, they freeze it to freeze the water in it, and then they cause the water to they cause the water to evaporate without going through liquefaction again, so that the solid state water is removed from that dura. So that's called lyophilized dura, and that is the dura that you use to cover. There is basically to treat it, and you cover the head, and it is one of like an interposition arthroplasty, like sort of what was described in the old days in the elbow. Elbow also has a lot of interposition arthroplasties. Without, you can do without or with glenoid reduction, as I said above. The rotator cuff is then reattached, and then you put this patient in an abduction splint, because when you leave them like this, they could fuse an abduction splint. And then after a few weeks, when pain is gone, you start range of motion. It is good for pain relief. You can also do resection arthroplasty after arthroplasty. Now, in this case, implants were there, infection setting, and then now you're doing resection arthroplasty. Now, in this case, you will usually find deficient bone. You'll find that even the humerus has been cut way below the head. You don't have a proximal part of the humerus. In the old type of resection arthroplasty that I just described, the way by Tillman, this humerus, if the deltoid is strong, can still migrate upwards and give you symptoms on the acromion. But in the resection arthroplasty, after removal of implants, most of the time, there is no bone. So most of the time, it's just a chubby, flabby limb that is not like the one you see on the left. So these patients don't have a fulcrum around the elbow, the glenohumeral joint. They don't have that fulcrum. So they get profound functional limitations, but they don't have pain. Apparently, they may have some pain if they try to move, but they don't have pain at rest. At least that is usually good. And so for patients who have had trouble, past discharging pain, and then you have done this, they actually are happy. When you look at most of the reviews in literature, they'll tell you that patients are happy that they don't have pain, because pain is not something that can give you peace. They will get about 30 degrees of range of motion in each direction, which is what almost like somebody who has a fusion can get. So on the right, the cut was a little bit proximal, and you now have a pseudarthrosis. Sometimes you can have this pseudarthrosis, and then in and of itself, it can become painful. The last option that one may have offer the patient is arthrodesis when things have failed. And the position to fuse this, when you're a registrar, you're taught the simple mnemonic of 30, 30, 30, 30 forward flexion, 30 internal rotation, 30 abduction. But you can vary that a little bit. The reason we want to abduct a little bit, maybe about 20 degrees, is to allow the patient, hygiene the axilla. The reason you want to move it forward and internal rotation is because the purpose of fusion, the only thing now you're aiming for is for the patient to be able to get the hand into the mouth to feed themselves or something like that. In this way, then therefore we are saying you cannot do arthrodesis on both sides. If you can't also do arthrodesis if the elbow is arthrodised, because now what are you doing? If the elbow is arthrodised, then you will do resection arthroplasty, because what you want is the patient to be able to get food to the mouth. And if the elbow is fused, if you arthrodise, they cannot even take care of themselves. Sometimes when you're fusing these arms, and especially when you have procedures happening on both sides of the hand, you need to be able to think about things that patients do, including eating and taking care of themselves, like hygiene and cleanliness and stuff like that. So those inform how you fuse. But when now you have finally decided you are arthrodising, usually it will be a patient who has had infection, or a young patient, you don't have the choice to put a joint. There is this old adage that you might fuse and then later on come and convert. I must say, I have not had the experience to convert an arthrodisc shoulder into a joint, but I think that would be a nightmare I'm not ready to face. I think that when you fuse a joint, the muscles are not moving. And so when the muscles are not moving, they atrophy. And if you go and replace that joint, there will be no muscles. So you are doing a joint for beauty, because the joint will not move. So in this case, if you think that the patient needs a joint, you better put a joint, and then later on come and do arthrodesis if the joint failed. Me, that is my philosophy. but people have their own different philosophies. I think that infection is one of the infection that you have controlled, chronic infection that you have controlled. You should not try to fuse when there is ongoing active infection, because the fusion will not work. It will become infected. When you finally choose to, you get a long recon plate, you run it from the spine all the way to the humerus, and you put bone graft, and you can make a construct like you can see on the left. Sometimes you can just put big screws, and the patient will be fine. You hold it out for some time for the bone callus to form, and then you start moving. All the movement that will happen in that fused shoulder will be scapulothoracic. So you can understand that scapulothoracic movement is limited. So these patients will have something like 40 degrees of each of those motions with very little internal rotation, because the scapula will not be able to internally rotate. Maybe a little bit of external rotation, a little bit of forward flexion, 40 or something less. The indications for arthrodesis in that case, as I've said, will be failed arthroplasty, or you have excised a tumor, you have a painful pseudarthrosis like the one I showed before, or you have a paralytic neurology or progressive paralyzing kind of neurology. You can't fuse if there's ongoing infection, or you have a acute phase of Charcot joint. We classify this stage 0, 1, and 2. You don't want to fuse. Lack of scapulothoracic motion, because as I've said, after you fuse, the patient is going to rely on scapulothoracic movement of this and to move that elbow and position the hand. And of course, if you fuse the elbow on that side. So in conclusion, shoulder replacement surgery is improving, and this is narrowing the role for the alternative options, but they continue to maintain an irreplaceable role in certain circumstances, as I've outlined, and arthroplasty carries major complications. So one should not just dash to do arthroplasty when there are joint saving procedures, because the best way to avoid the complications of arthroplasty is to avoid the arthroplasty in the first place. Thank you very much.
Thank you very much, Mark, for that beautiful lecture. I'm going to try and do the unmute thing so that people can make comments and have questions from trainees and so forth. Okay. So it's set in such a way now that you can unmute yourself. I wonder if there are any questions, if there are any comments, any clarifications whatsoever. I was just a bit curious myself about your experience with rheumatoid and diabetic shoulders. You're still muted.
Okay, sorry about that. I don't know what you mean by a diabetic shoulder. Could you elaborate?
Maybe more the rheumatoid.
You mean a shoulder in a diabetic patient?
No, I mean more like things like diabetic frozen shoulder, to be specific. And then the shoulder in the rheumatoid patient, where they could just have this progressive destruction of the shoulder joint. What has been your experience with that?
Okay, so for diabetics, my experience with them is at surgery during total shoulder arthroplasty. I have not had the situation where I have a diabetic with the frozen shoulder, but we see frozen shoulders as in and of themselves. And one knows that these shoulders, the most problem is range of motion. They go through phases, the phase 1, 2, 3, and when they have settled, they tend to regain. One should assess these people when they have regained, when they are in their later phase, to see the damage that is residual, and decide whether what you can offer that patient is, I mean, you can offer that patient anything better than what they already have. Because as we know, management of frozen shoulder is largely conservative, But we now have arthroscopic interventions where we do capsular release, capsulorrhaphy, and we inject steroids. So steroids in frozen shoulders can improve pain, and capsular releases can also increase the range of motion. But one is very cautious because sometimes these patients are able to regain useful function, and you might not give them what you promised to give them. In terms of the other one, other than frozen shoulder, was what?
Well, before we go to the rheumatoid, yes, could you make a comment on what you have seen with the Charcot shoulders as well in diabetic patients?
No, I have never encountered the Charcot joint.
I haven't ever seen one. I was just curious.
I've never seen one. I think this is what is still in books. I've seen a lot of those Charcot joints in the knees and ankles. I've not encountered one in the shoulder. Maybe as I pile up my experience, I'll be able to see some. But if I was to get one, I would go through the staging and see if it is still acute, and I would leave it and wait for it to be quiet. When it is quiet, then I would decide. Of course, this is an insensate joint, but the joint itself might be insensate, but there is some kind of motion around it. If there is motion, then we would determine what we would do with that joint. One can fuse. You can fuse a Charcot joint. You can, but it might fail if you're doing it in the acute phase. You can do excision arthroplasty. You can do excision arthroplasty even if it's in a Charcot joint. And I think some of these you can discuss with the patient and see what you can offer the patient. In rheumatoid arthritis, we've had that one. And the challenge about rheumatoid arthritis is that you tend to find tendon, calf tendon problems, and you also find bone osteoporosis a lot because of the medication they use and the disease itself. So my problem with these patients is that even when you go in at, because the advice will be, if they have not advanced a lot, go in and do a debridement. Synovectomy reduces pain in rheumatoid arthritis. So that you can offer early. But in later stages, when the disease has destroyed the joint, the best is a reverse shoulder arthroplasty, because those tendons are usually frail and torn, and so you are not able to repair them. And so and even when you repair them, they continue the progression of inflammation and destruction, such that those patients will not get very good outcomes with non-operative or non-surgical, non-arthroplasty methods. So the best there, unless you're going for a fusion, then the best will be a reverse if you're dealing with the rheumatoid arthritis. Even if you do a fusion, the chances of your success are also low because of this osteoporosis and persistent inflammation. Mm-hmm. So the best is usually a reverse for me in my hands for rheumatoid arthritis.
Thank you very much. If you haven't seen a Charcot shoulder, I think I'm lucky then. I'm unlikely to find one. And if I do find one, I'll just call you.
Okay.
We have a few questions in the chat box. Would you like to read them, or shall I?
Where should I click for me to read this? Let me see. Chat. Yes, chat. Yes. Yeah. What is the recommended drill size for decompression? A drill size that's about 2 mm. So if I have 3.2 drill bits, I would use it. What you want is somewhere around about 1 mm to 2 mm. You don't want anything bigger than that. I think actually 1 mm. So you could use a drill bit that is about 2.7 or maximum 3. 2.7 or 3. You can use it for microfracture. Oh, he's talking about decompression. Also for decompression, you have a choice to use multiple. Actually, you're supposed to use a cannulated drill. So you do wires to target the area where you want to decompress, and then you do a 4.0 cannulated drill bit. Thanks for your experience. What is your commonest indication for shoulder arthroplasty? And what's the commonest post-operative complications? I think he has, I'll answer him, but we discussed this. The commonest indication for shoulder arthroplasty is osteoarthritis by far. degenerative osteoarthritis accounting for 60% of these replacements in any centers. And the commonest, I don't know, commonest complication, I think should be, it depends on the time at which you are assessing, these patients. So earlier on, maybe the first few weeks after surgery could be infection, but later on, infection might not be a big problem. Implant loosening, implant wear, especially implant loosening, glenoid problems are the commonest problems going forward in the later ages. And then other things come later, like peri-implant fractures or peri-prosthetic fractures. So it is important to look at the timing when you're evaluating these complications. I think infection earlier on and later on, implant-related problems like loosening of the glenoid and peri-prosthetic fractures. So in our hands, we've gotten a few of those. We've gotten a peri-prosthetic fracture. We've not gotten a glenoid loosening, but my colleague has gotten a glenoid loosening. So it is possible to get those ones. You also will get wear and tear. Also, how early do you commence physiotherapy post-op? Okay, now, so it depends what you've done. I think we answered this question. If you've done an arthroplasty, I think he's talking in arthroplasty. I stand corrected. If you have done an arthroplasty, physio should start immediately. If it is generally for reverse, you start immediately, unless maybe you repaired the rotator cuff and you're worried that you're going to bust them open, your repairs. But most of the time, the physio starts up as passive, and then later on, when pain has gone away, maybe in another 3 or 4 weeks, the patient starts active elevation, then resistance training after about 8 to 10 weeks. So that is, physiotherapy is a little bit aggressive. If you've done these other procedures like arthrodesis and what, arthrodesis you might want to immobilize for 6 to 8 weeks before you start active motion. If you've done some of these interposition arthroplasties, then your movements will be much early because you don't want them healing and cicatrizing your joint. So it depends what really you've done. How long can the implant last before revision is required? Which implant? Which implant? Can John Esin, if he's still with us, be specific which implant? Is he talking about the reverse shoulder? Is he talking about the total shoulder arthroplasty anatomic? Hemi, is he talking about a resurface? I think generally, to answer him, like maybe he was talking about a reverse shoulder, because that's what I know most. Reverse shoulder is it will give you very good results in the first about 10 years, very good. And then from there, the performance starts to go down. It might not go down quickly for you to think revision yet, but complications start coming up. Glenoid loosening, implant fracture failures, or something is cropping up. But you will have good, retention of implants at around maybe 80% at about 15 years. So it is still good. It depends now how long the implant will last. Will depend on which implant you're talking about, how the operation was done, because as we do this more, we are getting the indications right and we are getting the science right. So now these implants are lasting a bit longer. So if you have attending pathologists and you have sorted them and you've done an anatomic shoulder, you expect it to last maybe 10, 20 years. If you have not sorted them, then that implant will not last long. And it might not be that the implant has failed. The operation per se has failed. But if you're talking about loosening of the implant, we've come to understand the science pretty well now that if you are able to respect it, this implant should still be retained at or above 10 to 15 years. And that actually informs how we decide when to do these reverse shoulders. That's why many people will say reverse shoulders should be done in patients who are older. And of course, if you go in the developed world, because they live a little bit longer, and then they tend to do them even more older patients. For us, maybe a little bit younger because our life expectancy also is not so much. I can see that there is no more question.
Yes, I think that's the last one. I wonder if there are any other questions, any other comments? Well, while we wait for further questions and comments, I'll just make one or two quick announcements. We're going to have to alter the login for the Zoom meetings starting from next week, Saturday. The reason is Zoom let me only book 50 meetings ahead of time. And believe it or not, we've done about 46 or 47. So it seemed reasonable to start off with a new set of 50 sessions at about the time when we're starting off the hand section rather than in the second week of hand, for instance. And speaking of the hand and upper limb curriculum as well, we'll be starting off with that from next week, Saturday. We have a textbook suggested reading in line with what the residents have requested. We have suggested reading already posted on the Telegram group, and one of them, the Greens, which is the more comprehensive text, is available there as an e-copy. So please feel free to dip into bits of it based on the topics we expect to learn on, just so that you can follow. Because I know that for a lot of us, hand is a bit esoteric since we tend to leave it to the plastic surgeons in Nigeria. However, there's so much an orthopedic surgeon can offer to a patient with a hand problem. And it ties in quite nicely with the upper limb sessions as well that we've been having, the shoulder and so forth. So I really do implore us to try to read a bit ahead just so that we can follow. The other reason is, hey, we're Nigerians for Pete's sakes. And we're having our South African brothers and sisters come to join us. So please, let's make an effort, guys. Having said that, I will circulate the new Zoom registration link via all the usual platforms, email, Telegram, WhatsApp, and so forth. Please register, and subsequently we have another 50 meetings, which will take us right through to the end of the year, really, for which the login links will be the same again. The other thing to say is that we have Mark's lectures on YouTube. Thank you very much, Mark, for your kind permission to allow us to save this. I think there are definitely talks that, particularly the biomechanics bits, that people should go through again. Per request of residents, I will continue to ask each and every person coming on the platform to teach if they mind very much for us to have their lectures stored in some way or the other. And for everybody who gives permission, yes, we'll do that, just so that you can have some kind of reading and revision material. We also will keep posting textbooks or articles and so forth via Telegram for people to read and revise. The other thing I should remind people about is from last week's lecture, Mark is very happy to, I say this on his behalf, he's very happy to teach and train anybody who wants to spend some time learning how to do upper limb work, so shoulder arthroscopy, shoulder arthroplasty, and of course you get your bug off. Your freebie would be the spine and the other joint arthroplasties that he does. He's an excellent clinician. I think this is a great opportunity, particularly with COVID. We can't go to America. Of course, we cannot go to India, even if they're going for free. and a lot of countries are closing up, and really for your own safety, Africa is probably the safest place on the planet right now. So it's great to know that we do have training opportunities in our area. You can feel free to reach out to him or to reach out to me, and I'm sure he'll be happy to facilitate your stay in some way. The only thing is, and it's not a but, it's just a fact of life. It's not a paid fellowship. but he's not charging you anything. But at least you have to pay your own accommodation and transport and so forth. I'm sure he'll be a fantastic host. And there are lots of wonderful things to look forward to in Kenya. There's the Kenyan tea, which is so strong, I don't think human beings should be drinking it, but that's, that's by the way. There's Kenyan coffee as well, which is exported worldwide. There are beautiful places to see in the country. There are lakes, there are safaris. It would be a lovely experience to visit Kenya again. I went to Kenya and I didn't want to come back home, really. I loved it that much. And I keep looking forward to going back. So that's definitely something for interested persons. We do have a growing pool of patients with upper limb problems in Nigeria. It's just that the way it is, most Nigerians will keep managing, but sometimes people are just looking for somebody who is able to help out. And then you find that in a year, your waiting list will just shoot up astronomically. So I think it's a viable subspecialty area for trainees and for young fellows to look into. There's so much you could do apart from spine and hips and knees. The other thing to say is that tomorrow we're having a lecture on hip. We're having a lecture on hip examination by Dr. Ibrahim Badib. I'm not sure if he's in the house today. Same time, same station. So we're running the parallel hip curriculum on Sundays, and we'll be running the upper limb and shoulder curriculum on Saturdays. And we'll just keep that up. We've had some fantastic hip lectures as well. And I think tomorrow will be a really, really good talk, particularly for trainees, because this is what you will definitely find in exams. You will examine one hip, one knee, one shoulder. You know, if you're unlucky, you get a hand, you know, and God knows what else comes along, particularly for the guys who are going for the national exams. You can be sure you'll find any pathology that we can discuss on this platform, since they have a huge pool of patients in Lagos and the patients are loyal, they always come. So I think a talk on examination is just fantastic, really. And it'd be a nice way to sort of step down after the, intensity of the biomechanics lectures we've been having in the last bit of time. I wonder if there are any further questions, or we can start proceeding to close the meeting, and to thank Mark very much. Okay, so we have a hand raised by Dr. Idumagbodi. Dr. Amokuto, please, you have the floor. Can't see the hand anymore, though. Okay, we'll see how that goes. You can always just reach out privately and have a chat later if you wish. So thank you very much, Mark, for honoring our invitation. Like I said, this will not be the last time you will come. You know, we're going to make sure one way or the other we drag you back to Nigeria, even if it's only virtually, or preferably in person one of these days. And I hope we'll also have people who get a chance to come and visit you and work with you in Kenya as well.
Okay.
And I will definitely call on you when we're building the next cycle of these lectures, which will be from middle of next year. Hopefully it will be a bit easier. We're trying to work on the structure to make things a bit easier for everybody, and we're still voting on that. So thank you very, very much once again.
My pleasure.
Yeah.
Bye-bye.
Bye. Okay, so for everyone left in the house, we do have a poll as well for people who, just to know whether we should keep up with the scheme of lectures we're doing presently, or if we should try and reduce it to once a week. So we have this going on Telegram. We'll just try and get as much feedback as possible. I don't know if people could just vote on their way out, if possible. and we'll see. Uh-oh. The poll is failing to launch. Okay, must be network. Okay.